All right. Let's talk about Chapter 13. So this has got really good stuff that you're going to use forever. Don't worry. Don't listen to me. I'm just talking. It's cool. Thank you, Anthony. I appreciate that, brother. You're a good guy. All right. Pay attention. All right. So Chapter 13 is all about vital signs and monitoring devices. If you've looked at that skill sheet, this is the end of your primary assessment, right? General impression, level of consciousness, chief complaints, and then airway, breathing, circulation, patient priority, and it wraps up with vital signs, okay? Then today we're going to talk about your secondary assessment and your reassessment, and that's going to be most of Chapter 14, okay? So with vital signs, one of the biggest things is, this is all in red, but pick keywords, right? Because it's not all like horribly important, but vital signs are important because it's the body's way of trying to tell you what's going on with it, right? You can ask people questions, they can answer those questions, but really taking vitals, and some of those vitals you can't mess with on purpose, right? You can't change your blood pressure to trick us. You can mess with your respiratory rate, but you really can't mess with your heart rate, right? You can't mess with your saturation. Does that make sense? Respiratory rate, someone who's faking difficulty breathing can change their respiratory rate, but they can't really mess with their blood pressure, their heart rate, their SpO2, right? You can if you hyperventilate long enough, but really it's your body's way of showing everyone on the outside what's going on with it, right? Skin color, temperature, conditions, a big one. The biggest thing to remember, and this is a good habit to get into, is what does one set of vital signs tell you? What do you think? Nothing, right? What does the second set tell you? A little bit. What does the third set tell you? A lot, right? So you're going to get way more from a third set of, and I don't mean like take one, a minute later take one, a minute later take one, right? If they're critical, your third set should be 15 minutes away, right? Non-critical patient, it might be 30 minutes away before you catch that third set. Does that make sense? So one set's great, but it's your starting point. Your second set's like, okay, it's changing a little bit. That third set is, okay, they're getting better, getting worse, or staying the same. Okay? Your third set of vital signs will tell you way more than your first set of vital signs. Okay, that's the biggest takeaway point on that stuff. Every single time you come in contact with a patient, you're taking vitals. Your non-transports, your cancels, your refusals, all of those you're getting vital signs. The only time you don't is if someone radios you and says, go away, right? Then you're not going to have any vitals. But if you come on scene, the patient's like, I don't want to go to the hospital, be like, hey, I need to get a blood pressure, get a heart rate, get a saturation, get a respiratory rate, do somewhat of an assessment so I can document it and kind of CYA when it comes to your report. Everyone know what CYA means? Cover your ass, right? And really with your reports, that's exactly what you're doing. Okay, Tuesday is all about reports, and you'll hate documentation before the end of Tuesday. I promise you. True story. So here is vital signs, okay, consisting of pulse, respiration, skin color, temperature conditions, so CTC, pupils, and blood pressure. Okay? One of the things, and this should be every single patient contact, one of the things that there's kind of this constant argument, what's one up there that you think should be there? Anybody got any guesses? Is there any vital signs you think you should have in every single patient? It's the first one. No, sorry, one that's not up there. Good call. You're like, I can read. Yeah, so glucose is the one, right? The downfall is glucose is not considered a vital sign. It's considered a procedure, right? Taking a glucose isn't a vital sign. It's an actual procedure. You're taking a needle, you're breaking the skin, you're causing the patient to bleed, right? It's good to have, but we don't consider it to be a vital sign, but you should get one of those in every single patient contact, right? We're going to talk about neurological here in just a second. What's another one that's not up there? It kind of is up there, but not by itself. We're going to get oxygen saturation in a second. Temperature is another one, right? An actual temp. This is take your hand, are they hot, are they cold? I want to know your actual temperature, right? And SpO2 is the other one. Believe it or not, before 2010, they did not let EMTs do oxygen saturations at the national level. When they made this transition course, which was transitioning EMTs from being an EMT-B to an EMT, they gave us all this curriculum and said, hey, we want you to teach EMTs these new things, new in quotations, that we're not teaching people. And the very first thing was how to put on an oxygen saturation. And we were like, we've been teaching that in Washington since the beginning of oxygen saturations, right? So that's why it's not on this list, is nationwide there are some agencies that don't have it, right? Here in Washington State, you're going to have it, okay? Term-wise, baseline vital signs are the very first vital signs that you obtain. And when we talked about, they tell you absolutely nothing, right? The repeat vital signs is that second one. That third one is the trending, right? Your second is a second set. It's just the repeat vital signs. And then your third vital sign is the trending one. Again, that's going to tell you the most about your patient's vitals. Make sense? Perfect. What are you looking at? You're supposed to pay attention. I stopped drinking coffee, so I'm just water today, so I'm real cranky. I've been at work since 10 o'clock this morning, so it's been a long day. No. I don't need it. What's that? Why is it like 4 shots? Nice, good call. Yeah. All right, so pulse, we're going to talk about the first thing, right? Definition-wise, it's the palpable pressure of the heart beating, right? When the ventricles contract, it creates a pulse. The best way to get a pulse is to trap an artery between your fingers and a bone, right? Carotid, radial, brachial, dorsal, all that stuff is you're trapping it between a bone and your fingers, right? And every time the ventricles contract, you get a pulse. For some reason, this eludes like half of the class on your next test. I don't know why. Does everyone understand that? Didn't think it was that hard, but okay. What? Don't worry, it's written right here. Can be felt by placing fingertip over artery where it lies close to the body surface and crosses over a bone. Okay? Trap an artery between your finger and the bone. Make sense? This is a person taking a pulse. Wow. Okay? So the textbook is going to tell you the best way is for 30 seconds, count the beats. Right? After 30 seconds, you're going to multiply that by 2. The only way to do this is if you have a watch on your wrist. What do you think is one of the best requirements during your internships? A watch, right? I have already talked to your preceptors. If you show up without a watch, they're going to send you home and you get no credit, right? Dead serious. You don't have one, go buy a crappy one. As long as it ticks every second, I don't care. I don't care if it's a second watch. Do they even make those? Bring a stopwatch. I don't care, right? You gotta. We'll have my cell phone. No, you don't, because you're not supposed to have your cell phone while you're on shift. Okay? You have to have a watch. Imperative to your job. Get used to one. Okay? Pulse rate normal for adults between 60 and 100. What's it called if it's less than 60? Bradycardia. What's it called if it's over 100? Tachycardia. What if it's over 150? It's a serious tachycardia problem. Okay? That's like ALS stuff. Come, fly them out. If you call MedStar on every call, we're going to call you Spokane County District 4. Don't let that happen. Or Stevens County District 1. You shut up. So above 100 is tachycardia. Bradycardia is less than 60. That's pretty easy, right? Know the definitions. Okay? Even better to know the breakdown of the word, tachy and brady, because every once in a while you'll see it with respiratory rate as tachypnea or bradypnea, right? Meaning slow breathing or fast breathing. Okay? Medical terminology. I told you it would mean something eventually.
That doesn't make you sound very smart.
Okay, yeah. This says 120, yeah, 150. 150 is a serious finding because 120 could be exercise, right? 130 can be exercise. 150 is a pretty darn serious finding. If you think about what stress does to your body, right, what adrenaline does to your body, if they just wrecked their car, that just probably broke that. If they just wrecked their car and their pulse is 130, that's probably not abnormal, right? Now, we find students saying, guy wrecks his car, and it's a pretty critical car wreck, right? And the EMS fighter takes their pulse and goes, well, it's 130. Well, you know what? You've just been involved in a motor vehicle collision. I don't think that's a big a deal, right? What also is a sign, or what's happening if their heart is faster? Is that a sign of shock? Yes, right? So if they're losing blood somewhere, their pulse is also going to be elevated. So don't get them to have them be like, don't worry, it's just because you've been involved in a motor vehicle collision. Now, if it's like a 20-mile-per-hour collision, okay. If it's 65 miles an hour, be thinking of shock, not just, oh, don't worry, you just been involved in a motor vehicle collision. We're not that worried about your pulse. And then they die, and you're like, now I'm concerned about your pulse because it's 0. Okay? The biggest thing, we'll go back to this for 1 second. If it's irregular, right? So let's say you're checking for a pulse, and in 30 seconds, you almost get in a habit of like a rhythm, right? If you have rhythm. Some of you, I'm sure, don't, like I don't, right? You'll get in a habit of like expecting it every whatever seconds, and all of a sudden they'll skip a beat. If it's irregular in any way, shape, or form, they want you to go all the way to 60 seconds, right? If it's irregular, they don't want you doing 30 times 2, just because that might give you an inaccurate number. Does that make sense? The cheater way that most of us will use, that I recommend you don't, is you can do it 15 seconds and times it by 4. Okay? Takes less time, but you're really, one person's doing this while one person's talking and doing something else. It's not like everything stops while this is going on. Make sense? So you got the rate. Okay? Now we're going to talk about the quality. Okay? So with quality comes rhythm is one of them, okay? The question you're going to ask, is it regular or is it irregular? If it's regular, it's a constant beat where the intervals are equally spaced. Make sense? That's easy. If it's irregular, this is shocking, the intervals are not consistent, okay? Usually we'll ask you, when you say my pulse is 20, I'm going to say, what is the rhythm and what is the quality? Does that make sense? Rhythm is 1. Is it regular or is it irregular? What's really sketchy, you move on to advanced EMT and paramedic, we ask you, is it regular or irregularly irregular? Right? And people are like, I don't get it. Because there's a big difference between regularly irregular and irregularly irregular, right? Is it like 2 beats and you drop 1 and then 2 beats and drop 1 and then 2 beats and drop 1? Or is it completely and totally inconsistent? Make sense? Right now, regular versus irregular. Be thankful. Come see me in a year and I'll totally mess with your head. Okay? Quality is the force side of things, right? You've got rhythm on one side, you've got the force on the other. You want to know, is it strong? Is it thready? Thready and weak are the same thing. Okay, conscious people, where are you feeling for a pulse first? Radial, right? Now, can you have a radial pulse and no carotid pulse? Yes. Can you have no carotid and have a radial? No. Because when your body goes into shock, the first thing it dumps is extremities, right? So you'll lose pedal pulses, you'll lose radial pulses, because it shunts it to the core. Once you lose a carotid, you're in cardiac arrest, okay? So when you're feeling that radial pulse, if you're feeling for it, you want to know what's the rate, what's the rhythm, what's the quality. The quality, is it thready and weak, or is it strong? Make sense? The big thing with this, not only do you want to know it, but when you do documentation, we'll talk about on Monday, you're going to document this. Okay? Radial pulse was weak and thready at a rate of 40. Make sense? The lower the blood pressure, the weaker your radial pulses and pedal pulses will be. Okay, I'll say it again. The lower your blood pressure, the weaker your radial and pedal pulses will be. Okay, because the less volume it's pushing out, the less it's going to get out to those outer extremities. Okay? Rule of thumb, and we don't teach it because it's not 100%, researched and guaranteed. If they have a radial pulse they have a systolic of at least 80. Okay? It's kind of like our, really bad shock patient. If you check a radial pulse and they got a pulse, their blood pressure is at least 80. Because anything less than about 80, you start losing that radial pulse. Make sense? So you can write it down. It's just like a quick rule of thumb, right? Radial pulse, it's at least 80 systolic. Okay, we talked about radial pulse found in the wrist, right? Used in patients 1 year and older, because less than 1 year we're going to go to brachial. Okay, look at that. That's a radial pulse. Okay, brachial for patients 1 year old and younger. Okay, separate bicep and tricep halfway between your elbow and your shoulder. That's a brachial. That's a baby. Carotid pulse felt along the large carotid artery on either side of the neck. Always feel for the carotid on the side that you're on. Don't reach across and pull towards you. And never let two people try to check for a pulse at the same time. You feel like this is self-explanatory, but it ain't. Right? The other one is do not massage the neck. Okay? If you look like fishing for one, don't massage the carotid artery. Okay? Massaging the carotid artery actually massages the vagal spot of your nervous system, and it drops your heart rate. Okay? The other thing it does is if they have plaque buildup and you massage it, you can break a clot loose and cause them to stroke right in front of you. Okay? So don't do it. Okay? Push straight in, check a pulse, straight out. Don't rub and do all kinds of weird stuff. The old rub-a-dub. Right? 30 seconds times 2. If it's an irregular rate or rhythm or something along those lines, go with 60 seconds. You're going to document the rate, the rhythm, and the quality. Make sense? Okay? Respiratory rate's the same thing, just different. No big deal. Okay, so this one's a little bit difficult. I will tell you in normal, non-ill people, this is very hard to get. Okay? So kind of the same thing. We want to know, what do you think the most important thing is? When you're checking for respiratory, what do you think the most important thing is? Are they breathing? On the very next test, there is a question that asks along the lines of what's the first thing you want to know with respiratory? It's not the rate, it's are they breathing? Right? Pretty straightforward. Respiratory rate's number of breaths in a minute. Okay? We're also going to talk about quality. Is it normal, is it rapid, or is it shallow? Okay? Normal is normal. Rapid's too fast. Slow and shallow would be not enough. Make sense? That's easy. Okay? Normal rates for adults, 12 to 20. And of course, respiratory rate is determined by age, gender, size, physical condition, emotional state that influence breathing, and so on. Don't write the number 24 down right here. Write the number 28 down. Anything above 28 or anything less than 8, you're going to bag them. Okay? Unless that over 28 is due to something like anxiety or something along those lines, right? You got to compare that 28 and their level of consciousness and adequate versus inadequate. But definitely anything less than 8, you're going to bag them. Okay? In test questions, pay attention to vital signs. Because what the NREMT will do on purpose is in the trauma section, they'll give you a good scenario that will be, a skateboarder who's skateboarding, falls off a rail, smashes his chest, he's got a flail segment, he's bleeding, yada, yada, yada. What's the first thing you're going to do? In the test question, they'll tell you that his breathing rate is 4. But then they give you all of these injuries. Usually breathing rate of 4 is like in the first sentence, and then they give you 4 sentences of injuries and so on. And then your answer options is like, are you going to bag him? Are you going to stop the serious bleeding? Or are you going to, stabilize his chest or whatever? What they assume is you miss the fact he's only breathing 4 times a minute, right? Anything less than 8 gets a BVM. There's no other treatment for that. Make sense? So your categories for quality, normal, shallow, labored, noisy. Okay? Shallow tidal volume that is concerning. Right? You can say tidal volume of less than 300, but there's no way to measure tidal volume, right? Not accurately. Okay? Labored is the rate's fast, they're working hard to breathe. Noisy is you hear stridor, you hear gurgling, you hear snoring, you hear wheezes, something along those lines. Okay? In the class, when you do a scenario and you say, you know, my respiratory rate's 14, I'm going to say, okay, what is the rhythm and what is the quality? Does that make sense? Just like pulse. I want to know rate, rhythm, and quality for both your pulse and your respiratory rate. Cool? It's easy. So respiratory rate's a little bit tricky. It's easy on paper. You count it for 30 seconds, you times it by 2. That's easy. The hard part is physically counting this, right? So a couple of tricks. One, if you tell the person, I'm going to count your respiratory rate, what do they start thinking about? Breathing, right? So now they're going to inadvertently change their respiratory rate, right? Right now, if I tell you I'm going to count your respiratory rate, you're already thinking of breathing, right? And you're subconsciously breathing when you think you should breathe, not letting your body do it itself. So the trick is if you take their hand and put it on the pulse location and put it across their chest, the first 30 seconds you're counting respiratory, the second 30 seconds you're counting their heart rate, and then you take those two numbers and double them, and now you have a respiratory rate and a pulse, right? That way they think you're checking a pulse, okay? If you're having a hard time feeling it or hearing it, put your hand on their back. You can have them sit up. You can take your stethoscope and try to hear it. Listening in this class, you'll get great, and then we're going to put you in the back of an ambulance going down division at 60, right? And then you're not able to hear crap. So get used to it here, and then ask people, hey, what is your tricks of the trade when taking blood pressures while moving, or heart rates while moving, or respiratory rates while moving? Practice them on all kinds of people, right? If you want to check out a blood pressure cuff and a stethoscope to take home, take vitals on every single family member that you have, right? Blood pressures, heart rate, respiratory rates, all of it, right? Don't do random people. It's awkward. But at least do it on people that you know, right? Or you can put a sign up that says EMT student at Walmart. I'm sure you get all kinds of free blood pressure clinic people.
Well, how do you take the respiratory rhythm? Are you saying you just like feel their chest?
Yep, you're just feeling their chest rise and fall. Yep, because sometimes you can't see it, right, because of clothes or whatever. With your hand on their chest, it allows you to actually count up and down. Good question. You girls okay back there? You guys good? Just checking. All right, so here's stuff that was not in your book that's important to you as an EMT, okay? It's called end-tidal CO2, okay? You can call it waveform. You can call it end-tidal CO2. I don't care. End-tidal CO2 is written as EtCO2, okay? So what this is, it's the amount of CO2 that you're exhaling, okay? So we use this to measure because up until now, we've always looked at oxygen saturations, which is a good tool, but if your body breathes based on CO2, this allows a little more accurate way of looking at how you're breathing. Does that make sense? I'll show you the devices here in a second. Normal is 35 to 45 millimeters of mercury, okay? On the monitor, if you have this capabilities at your agency, it will have a spot that says end-tidal CO2 and a spot for a number. 35 to 45 is normal, okay? Anything more than 45 means they're breathing too slow, right? Anything less than 35 means they're breathing too fast. Does that make sense? When you're using this during CPR and chest compressions, anything less than 10 millimeters of mercury means whoever's doing chest compressions is not doing a good job, okay? They're not circulating blood through the body to get CO2 out of the respiratory tract where it belongs, right? It's sitting in the bloodstream somewhere. Does that make sense? So you're looking at this number, and it's end-tidal CO2 of 10. Change your chest compressor. Oh, that sucks. Anybody have a preference on ice cream? Nobody has a preference on ice cream?
For free ice cream, I like it.
For free, I don't care what it is, right? Ice cream sandwiches are the cheapest. Okay? So here's, with good chest compressions and good ventilation, you should generate an end-tidal CO2 about 25 to 35. Okay? It's inaccurate to think you're going to get a perfect CO2 with chest compressions. It's impossible, right? So good chest compressions should get you about 25 to 35. Okay? So if this is continuous, right, that's the nice thing about end-tidal CO2. It's a continuous monitor of that CO2 in what's called ROS. ROS stands for return of spontaneous circulation, right? You're doing chest compressions, all of a sudden they get a pulse on their own. You'll get this spike in CO2 because now all that CO2 that's been sitting in their bloodstream because of anaerobic metabolism, it all of a sudden now circulates into the respiratory system. They start blowing CO2 off like crazy, right? So all of a sudden your 25 or 35 will jump to like 60. Check for a pulse because they have one, right? With end-tidal CO2, we're actually recognizing patients are returning of spontaneous circulation faster than before, right? It's awesome. It's good stuff. This is the other thing is if you put it on while you're bagging, now you can actually bag the patient based on their CO2 levels, right? Which is what their body's used to breathing on anyways. So if you're bagging at a rate of 10 like you're supposed to, you'll maintain a end-tidal CO2 about 35 to 45, okay? If you notice their CO2 starts to fall, you're hyperventilating them. You're bagging them too fast. So slow your breathing down, right? If you notice it's starting to rise, then you need to speed up your breathing because you're hypoventilating them. Does that make sense? The faster you bag, the lower your CO2 goes because you start blowing off CO2, right? The slower you bag, the higher your CO2 gets. Does that make sense? So here's what's nice about it. So the one that we're utilizing now is a nasal cannula that has a device on the end of it. One nostril is administering 2 or 3 or 4 or 6 liters of oxygen, and one nostril is actually reading the amount of CO2 you exhale, right? It's why it looks so funny, right? It looks ridiculous. It looks like a binky attached to a nasal cannula. Okay? I like it, right? The other one is this is one attached to an ET tube. They also attach to a King Air. It's a device that goes between your King Air and your BVM, and this hooks to your monitor, and it reads when that bag is exhaling. Okay? So those are the two devices. One other thing that waveform gives you, end-tidal CO2 on its own is just a number, right? It tells you 35 to 45. Waveform actually gives you a wave. Okay? Normal breathing should produce a rectangular-like wave. Okay? The first part of this is expiration, and the back part of this is inspiration. Okay? It should be this nice rectangle. That high point should range about 35 to 45. Okay? 40 is where this dotted line is. Does that make sense? Normal respiratory rate with no problems makes this nice, good rectangle wave. Does that make sense? Now, here's the nice thing. When you compare these two, asthma and hyperventilation, side by side, how many of you ever had an asthma attack? Anybody? Or know what an asthma attack happens, right? What happens in an asthma attack? The rate goes up, right? Your tidal volume goes down. Does that make sense? Now, when you hyperventilate, because let's say you're having an anxiety attack, what happens? Your rate goes up, your volume goes down. So side by side, they present identically, right? Walking into a house with a 14-year-old kid, I can't tell you the difference between asthma and hyperventilation right off the bat, right? Anybody know one of the side effects of albuterol is? What do you think? Rescue inhalers, albuterol. What's one of the side effects? Anxiety, right? So if you gave albuterol to a patient who's hyperventilating, what are you going to do to them? Make them worse, right? So you would try to not give them albuterol. On waveform, your asthma, because of the bronchoconstriction, changes your wave to look like a shark fin. COPD and asthma patients present with a shark fin. Okay? The nice thing is hyperventilation is still rectangle, but it's closer together. So with end-tidal CO2, you can tell, is this an asthma attack or are you just hyperventilating because you have an anxiety attack? I can give albuterol. I'm not going to give it because it'll make them worse. Right? It's a huge tool of diagnosing people with respiratory problems and finding out the actual problem. Make sense? So here's skin, right? This is that CTC we talked about, color, temperature, and condition. The nice thing, this is one of the vital signs that you can't mess with. Okay? This is one of the vital signs that truly is following what your body is trying to tell you is wrong on the outside. Okay? What part of your primary assessment are you getting your skin CTC in? Under what part, though? circulation, right? Airway, breathing. Under breathing, you really care about are they or are they not? And then when it comes to circulation, do they have a pulse? What is their skin CTC? And then when you take vitals, you want to know rate, rhythm, and quality of both heart rate and respiratory rate. Make sense? So color-wise, best places is nail beds, inside of cheek, inside of lower eyelids. Okay? If they're Caucasian, this is pretty easy just about anywhere. You can look at their face. They're dark skinned. This is somewhat kind of hard to see. So looking at nail beds, you can look at the whites of their eyes. Inside their cheek, inside of lower eyelids is a good place to look at that skin color. Okay? Pale means what? Lack of blood. Right? Cyanotic means lack of oxygen. Flushed means too much blood. Right? Jaundice is always liver. Right? So pale's lack of blood, cyanotic's lack of oxygen, flushed is too much blood, jaundice is a liver problem. And jaundice is yellow. Okay? Jaundice, sometimes it's kind of hard to see in the skin. The whites of the eyes, jaundice shows up really, really well. Okay? You go on chronic alcoholic patients or liver failure patients, you'll see what jaundice looks like. Because that happens a lot. Make sense? So pale, lack of blood, cyanotic, lack of oxygen, flushed is too much blood, jaundice is a liver problem. Make sense? That's just color. That's the 1C. Here's the T, okay? So here's the problem. Most textbooks, you'll see the picture where the EMT or the paramedic has pulled their gloved hand back and they expose the back of their hand, right? They take the back of the hand and they put it on the patient's skin. Now, the downfall, if you've ever worn gloves before, how hot is your skin inside your gloves? Pretty darn hot, right? I'm a big fan of like inside my arm, right? Inside an arm across their forehead, you can feel if they're warm, if they're cold, or if they're cool. Okay? Look at that. Great picture. So condition then, where's condition? Condition's not that weird. Condition you're looking, is it sweaty or diaphoretic? Okay, diaphoresis and diaphoretic means sweaty. If you see that in a test question, which you will, diaphoretic or diaphoresis means sweaty. It's just the way that they're interchangeable. Diaphoretic or diaphoresis, they use them interchangeably. It's like capnography or what's the one? It's like the CO2 one. Hypercarbia, hypercapnia, they use them just interchangeable. Okay, with kids, you're going to add one more, which is cap refill, right? So you're going to take their nail bed, you're going to squeeze their finger until it turns pale. You're going to let go and count how many seconds it takes for it to go back to pink. Okay? Normal cap refill is less than 2 seconds. Anything over 2 seconds is a sign of shock. You good? Anthony's over here pushing those fingers. I like it. Can you do cap refill on adults? Absolutely, right? When we get into trauma, when it comes to like broken bones, you're going to do cap refill on below broken bones, right? Because one way you're going to tell, are they getting blood flow below that broken bone? Okay, but for sure, in children under the age of 6, you're going to do cap refill. Okay, next comes pupils. Okay, so pupil is the black center of the eye. Okay, when you shine a light in their eye, it should get smaller. Okay, when you take the light away, it should get bigger. Bigger means dilation, smaller means constriction. Okay, so you want to know like 3 things. It's probably one of the misconceptions about pupils. First thing is you want to know in a normal lighted environment, what do their pupils look like? Okay, then you're going to shine the either side, right? You're going to shine the light in the right pupil, and you're going to look at the right pupil. You want to know if when you shine the light in the right pupil, does your pupil constrict? Does that make sense? Take the light away. And then while looking at the left eye, you're going to shine the light back in the right pupil because you want to know if the left pupil changes with your right pupil. Make sense? Then you're going to go to the left eye. You're going to look at the left eye. You're going to shine the light in the left eye. You're going to take the light away. You're going to look at the right eye, and you're going to shine the light back in the left eye to see if they constrict together. So you want to know, what is it normal? What is it when it gets light shined into it? And does it follow the other eye? Make sense? because certain issues will have unequal pupils, and we'll talk about those here in just a second. Okay? So baseline, look at that, I just did that. Cool. Most of your pen lights will have a gauge, right? If you're going to go buy your own pen light, they're not very expensive, buy one with a pupil gauge. Okay? Because when you document, it makes you sound intelligent. Okay? Normal, I think, is about 4 to 5 in like a normal lit environment. Right now, you should all have pretty dilated eyes. When I turn the light on, some of you still might have really dilated eyes. No one caught that? The reefer? No? All right, well, let's move on. All right, so you're looking for size. Are they equal and are they reactive? Okay, one of the acronyms I put over there is PEARL, P-E-A-R-R-L. Okay, that's normal. It stands for pupils equal and round and reactive to light. Okay, it's this one right here, P-E-A-R-R-L. Pupils equal and round reactive to light. Okay, do not document PEARL if you haven't checked the eyes. Right? It really, really pisses people off if you lie. Okay? So look at their size. They're round. Are they equal and do they react to light? Pupils equal and round reactive to light. You can have a pupil like if they're ruptured, you can actually have a pupil that looks like it's like half moon or something along those lines. Damn it, like a lot of like blunt force trauma to the eye can do stuff like that. Make sense? So this is pinpoint. What's this usually a sign of? You don't have to go right to heroin, but opiates in general. Good call. Welcome to Spokane. Okay? It's a opiate drug. Okay? Dilated pupils. Welcome to Washington and Colorado. The pot, the reefer, right? And then unequal pupils. Now this has got a couple of bad things. And in fact, 20% of Americans have unequal pupils, right? There's a medical term. It's like anoscortia, I think is what it's called, right? 20%. Now, in that medical condition, they're only different in size by 1 millimeter. In head trauma, in strokes, in brain bleeds, they're more than 1 millimeter apart. So you'll have one that's pinpoint and one that's blown, okay? And we call this unequal. Usually you'll hear us say a pupil's blown and a pupil's pinpoint. They don't react to light very well, right? The other term that you'll hear is when we say fixed and dilated. What does fixed and dilated mean? They're gone, right? Fixed and dilated is dead, right? Dead people have, because their brain tissue is not even perfusing, they're not letting the ocular nerves act like they're supposed to, they're gone, right? Fixed and dilated is a really good way to tell if your patient's brain dead, okay? Ooh. So this does say you can, topical drugs you can put on one eye can cause this as well, right? There was a time when we used to have people that were putting LSD patches inside their eyelids, right? That'll really mess with your eyelids, right? Because it's acid, idiots. All right, so blood pressure. This word right here, go ahead, I don't care. That's the word, right? That's a really, really good extra credit question. Like, what is the proper spelling of a blood pressure cuff, right? I've had a couple of students that get it right. If you can pronounce it, it's spelled just like it sounds. So I've been told. Stigmographer. That's what I think it says, right? Textbook tells you your blood pressure cuff should cover 2/3 of your upper arm between your elbow and shoulder. People miss this test question and want to argue it. I'm not going to give you the point because the answer is it should cover 2/3 of your upper arm between elbow and shoulder. Make sense? That's easy. Make me nervous, Anthony. You're freaking me out. Quit staring at me. Right? So, just above the elbow, 2/3. Go, stop it. Okay? So, a palpable blood pressure, you can write that down, palpable blood pressure does not use a stethoscope. Palpable blood pressure does not use a stethoscope. An auscultated blood pressure uses a stethoscope. An automatic blood pressure is a machine. Okay? Palpable blood pressure does not use a stethoscope. Auscultated blood pressure uses a stethoscope. Automatic blood pressure is a machine. Which one do you think is the most accurate? Auscultated blood pressures. Okay? What's your backup plan? Palpable. What's your third plan? The machine. In the hospital, they no longer take palpable or auscultated blood pressures. They use machine every single time. One of the reasons why we've removed that as a requirement, you guys used to have to spend 12 hours in a hospital, 12 hours on an ambulance in this class, right? We sent out a survey and asked a bunch of students who went there in the past and said, hey, what did you get out of it? And they said nothing, right? Because you were there to take vitals on lots and lots of people, but they don't do auscultated or palpable blood pressures in the hospital, right? They don't have time. There's too much stuff going on. So we've removed that requirement. You're going to do 2, right? You'll also work on ambulances where the very first thing the EMS provider does is put them on an automatic blood pressure cuff, right? Be like, hey, do you mind if I take an auscultated blood pressure? And they're going to go ahead. Okay? I love this. Prepare the patient. Okay? So first thing you're going to do, if you've never taken a blood pressure before, pay attention. If you already have, bear with me. Okay? You're going to find the point at which the brachial artery crosses the elbow. Okay? It's usually dead center. Okay? Every once in a while, it's towards that inside. Make sense? So you're going to pay attention to the blood pressure cuff that's got this stitched directions for you to follow. It's a picture and everything. Okay? If the blood pressure cuff is on the right arm, you're going to put the artery where that arrow is. If you're putting on the left arm, you're going to put the arrow on that artery, or the artery on that arrow. Okay? This is the patient's left and right, not yours. Okay? You're going to put this on tight, okay? And you're going to put the stethoscope bell, the end that you listen with, you're going to put it where you feel that pulse. If you can't feel a pulse, put the blood pressure cuff on, pump it up a little bit, and provide some pressure, and you'll feel that pulse. Okay? Once you feel a pulse, put that bell right where your fingers are, and then take your fingers away. Okay? Make sense? You want this gauge somewhere where you can see it. It's very important in the next process. Okay? You'd be surprised. Okay? We're going to talk about how to use the stethoscope properly in a second. So, it's got a bulb, right? Remember bulb, and it's got a valve on the end of it. You want to make sure that valve is closed. Spin it one direction, pump it up. If air runs out of it, spin the valve the other direction. Okay? Lefty loosey, righty tighty. Make sense? Close it, and you're going to pump this thing and the bulb until this gauge, the textbook is going to tell you 30 mLs higher than the point the pulse sound disappears. So if you do it like the textbook, you're going to pump it up a little bit. You're going to hear thump, thump. So you're going to pump it a little more, and it's going to go thump, thump. You're going to pump it a little more, and you hear nothing. You've gone far enough. I will tell you, most of us have like rules of thumb. Every single person in this room, I would run that gauge to 140, and that's my starting point. Right? If I hear a pulse at 140, or if I hear a beat at 140, then I'll go to like 160. Make sense? You got a little 90-year-old lady, and you run that thing to 140, and you're going to hurt her. Right? And she's going to go, ow, and she's going to slap you. Don't do it. Right? I've seen EMTs who do this improperly. When you take the cuff off, the patient's arm is bruised circumferentially. Okay? Little old people's skin are super, super delicate. Okay? I've seen it tear their skin and make them bleed. I've seen it bruise their skin. Do not rack that blood pressure cuff as high as you can. Okay? It's mean. Okay? The last class when we did testing, I had to be one of the students' partners, and a friend of mine was in the station as the patient, and so I wrapped the needle clear all the way around and started making my way back up the other side. Right? That left a pretty cool bruise. Right? Don't do that to people with me, unless they're your friends. Okay? So you inflate the cuff, okay, until it gets there, and then you should hear nothing, right? It should be where it's silent. Now you're going to pay very close attention to the gauge, and you're going to crack that valve. Okay? Just a little bit. What you want is this needle to start to fall nice and slow. If you open it all the way, the needle's going to fall clear to zero. You're never going to get a blood pressure. Okay? So crack it just a little bit and let it start to fall. Now you're going to pay attention because all of a sudden you're going to hear thump thump, right? That very first beat, wherever that gauge is at, that's your systolic. And then it's going to keep falling. Thump thump, thump thump, thump thump, thump thump, and then nothing. Right? The last beat that you hear is your diastolic. Does that make sense? First beat you hear is systolic. Last beat you hear is diastolic. If you can't hear one, dump all the air out of that cuff, take the cuff off, switch arms, do it again. If you can't get it a second time, admit it. Right? Hey, I can't hear blood pressure. No big deal. We'll try. Okay? The last thing we want is for you to lie. Okay? I've had firefighters do it. I've had paramedics do it. I've had EMTs do it. I've had EMT students do it. Right? You tell me 120 over 80, and that's, I think you heard it at 120 over 80. I get in the ambulance, and I take their blood pressure. It's now 80 over 50. I think they're dying. Right? So I start dumping fluids. I start looking for bleeding. If their blood pressure was always 80 over 50, you just maybe do a bunch of stuff that wasn't meant to be done. Or vice versa. You say 120 over 80. I take it, it's 200 over 120. I think they're having a stroke. Right? Don't lie. Just admit, I can't hear it. The very first sign we know that you're lying is there is no lines in this blood pressure cuff for odd numbers. Okay? The little lines are in twos. And we have students, 123 over 67. Liar! Right? We're like, yeah, try again. Okay? There's big black lines, and there's little black lines. The little black lines are in twos. Okay? Be accurate, get good at it, figure it out. You have plenty of time to practice. From this point on, you come to class early, go get a blood pressure cuff and a stethoscope, and capture every person at the door and take their blood pressure. Take one home. Your wife, your girlfriend, your husband, your boyfriend, random people in your house, I don't care. Take blood pressures over and over and over again. Don't do that. That'll get you arrested. Don't be like, hey, I got a hotel room. You should come. Let me take your blood pressure. Go ahead, McKenna. So once you hear a beat, right, the last beat you hear, you're supposed to go 30 above that. Most of us, like I said, go, all of you, I'd go to 140. If I hear a beat at 140, I'll go to 160, and then 180, and then 200. You just have to find what works for you. The textbook is going to tell you 30 above the point of where the sound disappeared. Does that make sense? So if you hear something at 120 and you go to 120, or let's say you go to 130 and you hear nothing, then you're supposed to go 30 above that. Does that make sense? There's no need for that. I would get in the habit of like 140 to start. If you hear something, go to 160, then 180, and so on. Does that make sense? What did you say? Sorry? Like 100. Start at 100, because usually their blood volume is really, really low. Right? And not just little old people, period. Right? Old ladies, old men. 100, then like 120, then 140, then 160, and so on. So anybody less than the age of 3, blood pressures are almost completely worthless. Right? But you know a kid, their blood volume's low anyways. Right? So if it's a 4-year-old, go to 90. Right? If they're 6, go to 90. If you hear something, go to 100. Does that make sense? Just like gauge based on that person. The nice thing is the kid cuffs are smaller, so you won't get a lot of that pressure when you do it with a kid cuff. Talked about that. So there's the 3 years and younger thing. Okay, blood pressure monitors. This is easy. The blood pressure cuff goes in the same spot. You just push a button, right? It inflates, it deflates, and it gives you a blood pressure. Okay? The downfall is these are real susceptible to bumps in the road, jiggling of the tubes, and they just make them inaccurate. Where's the palpation one? Dang it, it's not here. That's right. So, oh, it's right here. So, just kidding. So here's by palpation. That was auscultation, right, because you're using a stethoscope. So let's say you can't hear one and you still want to get an accurate blood pressure. Blood pressure cuff goes in the exact same spot, okay? You feel for a radial pulse, okay? You find that radial pulse, you start blowing up that balloon, okay? You can do the rule of thumb. Find the pulse and then blow up to 140. You want to go, that one you want to go 30 above when you do not feel a pulse, okay? So you want to pump it up to actually, and it's not the true word, but tourniquet the arm, right? You're going to pump it up till the pulse stops, okay? Nice and slow, crack your valve and let it fall. The very first time that you feel that pulse, that's your systolic. Make sense? You cannot get a diastolic with palpation. So all you're looking for is a systolic, and then you get rid of that, the rest of that pressure out of that bag. Then you write down 120 with a line, and you put the letter P, which means you took it by palpation. Does that make sense? Feel for a pulse, get a pulse, crank that blood pressure cuff up till you lose it, crack your valve nice and slow, let it fall. The second you feel a radial pulse, that's your systolic, and then you just write a line and write P. That make sense? Pretty self-explanatory. Say again? So everyone kind of has their own, like if you can't hear one, it's better than your blood pressure cuff, your machine, right? So that's one way. The other one is when you go to like advanced EMT and paramedic, once we already get a good auscultated blood pressure and I want to give you fluid, I might just quickly, because it's faster, quickly take a palp and be like, okay, your blood pressure is 90, I'm going to give you fluid, right? So sometimes trauma, you might do that as your second vital sign, maybe your third vital sign. Auscultated is still the very best one because it gives you, we're going to talk about when we get into trauma, not only does blood pressure give you a systolic versus diastolic, we also look at the difference in the pulse pressures because if they're narrowing or widening, they're two different problems. They should fall and rise together, right? And we get into trauma. We'll talk about that a little bit. That's a really good question.
Are they normally 40 apart?
That's like the perfect, right? Within about 40 to 50, they should be about that far apart. If they're closer than that or farther apart, we got problems.
What are extremes?
We say widening or narrowing, right? If you notice they're getting closer and closer together, that's a narrowing blood pressure. It's actually a sign of a head trauma. If they're widening, it's actually a sign of something's compressing on your heart, right? So when we get into trauma, we'll talk about both of those because they're both involved in a couple different things. Good question. Temperature, right? Temperature's good. Notice how it's not in red because this is, I mean, it's easy, right? Your normal temperature is varied by a bunch of things, right? Your age, where it's taken, how much activity level you had, what time of day is it, that kind of stuff. And oral's great, right? Tempatic is where most of us have gone, right? Just the ones that go across the forehead. That's the best one, right? Because it's just quick and easy. Let's take a quick break. Stand up, stretch,